Have about 4 seconds.
Good morning, Labor, Health and Social Services. Happy Friday. Apparently there's one senator in the building today. He's joining us. Marilyn, if you'd call the roll, then we'll get started.
Good morning. Representative Chadwick.
Here.
Representative Clausen.
Here.
Representative Hornop.
Here.
Representative O'Hearn.
Here.
Representative Penn.
Here.
Representative Trujillo.
Here.
Representative Ward.
Here.
Representative Yin.
Here.
Chairman Swanitzer.
Here.
Thank you.
All right. Representative Penn. How about you pick which bill you want to do first? Just because you weren't here at our last committee meeting?
Don't make any sense.
You have a, we'll do Senate File 8 first. With that, Senate File 8, welcome Senator Baldwin to discuss essential subsidy payments to behavioral health centers.
Thank you very much, Chairman. Thank you, committee, for spending your time with me this morning. My alarm clock went off in my head. I was tempted to get in here much early, but you all were probably in bed sleeping. So the first bill, and I am doing all three of these, and I would tell you up front, all three of these at one time or another have been committee bills. One is the one that's blue, the one that comes engrossed is a committee bill from this year. 08 doesn't come out of the Labor and Health Committee, but it comes out of the Behavioral Health Remodel Group and the Behavioral Health Task Force. So technically it could be a committee bill. And Medicaid licensed 09 was a committee bill from 2 years ago. They didn't make it all the way through the system. So technically they could all be committee bills, if that makes me feel any better. But number 08 is essential subsidy payments to behavioral health centers. The behavioral health remodel, and some of you weren't here last year, we passed a bill. The behavioral health system, we've been missing the mark for a long time. People are slipping through the cracks. We're not getting to the people that necessarily need the care. We've overloaded our state hospital. We've had, the beds are full. When we wanted to get somebody in there, it was a difficult thing to do because they were lingering. I believe you all heard the bill about the court cases, the misdemeanors, getting them into the community health centers. That's a piece of this, although it went through judicial. This is another piece of that. And you will have more. We have more months ahead of us, as somebody behind me will let you know. This is a very small piece. The way that behavioral health right now is assigned out to people is by counties. And as you know, in rural Wyoming, which most of Wyoming, frankly, is quite rural, it's assigned by counties. A county is not necessarily equivalent. And I will use my county as the example because it's a pretty good example. We have a lot of behavioral health people in the portion of the county where there's a lot of people. Outside of that, there's a lot of small rural communities with very little or no mental health system or no mental health providers. It becomes a real problem. And as these have combined into multiples that cover more than one county, it becomes even more of an accentuated problem. In the small places where we need those, sometimes they're not available. So if you look on page 2 of this bill, you will look at the only change there is we changed the geographic, the way we define the behavioral health centers, or not the behavioral health center, but how the service needs are demonstrated. And where we've created a model, or we're creating a model where we do it by the population and not necessarily by where the county, how many are in each county. And to add to that, and there again, the folks behind me will tell you a little bit more about that. But a lot of these behavioral health folks are identified. They may be working in the school systems. They may be somewhere else besides in the community mental health center. So it's quite a diverse, and we just needed a way to identify where those professionals are, where the needs are. And this is a first step in identifying where those needs are. So it's a very small change. I say you will see more as those committees move forward and the task force move forward. With that, I don't do questions, but the folks behind me will have some more answers for you and can explain it probably a little better than I can.
Any immediate questions for Senator Baldwin? Not seeing any. Department? Welcome. Dr. Hanson, go ahead.
Good morning, Mr. Chairman, members of the committee. Stephen Johansson with the Wyoming Department of Health. Chairman Baldwin did a good job explaining this bill. I'm glad that more than halfway through the session, we can discuss some relatively simple bills with you. I will say that this redesign effort that we've been engaged in for the better part of 2 years at the direction of the legislature, I'm very optimistic. I think we're on the right track to do something innovative and unique and something that will sustain Wyoming's behavioral health continuum for for years, if not decades to come. It's been a really robust effort with the executive branch, with the legislative branch, and with the provider community who I couldn't be more thankful to, our mental health and substance abuse providers for partnering with us to get this right. By way of background, the behavioral health redesign is scheduled by the legislation to be implemented on July 1st of 2024. So we have some time, and the past 2 interim cycles, we have been working through various components of that reform model. Most recently in the 2022 interim, we really worked through with that stakeholder group of executive branch, multiple agencies, legislators, and provider community. We worked through payment model pieces. And this is one item that came out of that work in the 2022 interim, which was in the original legislation for the behavioral health redesign, which established the department having what we call essential subsidy payments. As Chairman Baldwin mentioned, there are centers who serve very small and very rural populations, and then we have centers that serve quite larger populations with bigger population centers. The reason for the subsidy payments originally, as it was contemplated, was to be able to equalize that given the missions we were giving to the behavioral health centers through the reform. Some of those centers would not have the same kind of population of state hospital clients, corrections clients, Department of Family Services clients that you might see in a Casper, a Cheyenne, a Rock Springs, Lander, Riverton. So that's where the essential subsidy payment concept came from in the establishing legislation 2 years ago. And you'll see it's just striking the shall language and tweaking the definition a bit so that we have the ability to provide those essential subsidy payments should they be needed. And this was really a discussion with the provider group who recommended that we make this change in the statute to make it permissive as opposed to required. And again, we worked through the details. The department and my staff had proposed different ways for that model of essential subsidy payments to work, as you can see, defined in certain geographical areas. But it really became clear during those conversations that with the payment model we are planning to implement, it has 3 components. One is base payments, which is kind of infrastructure payments to those centers to keep the lights on, keep the doors open so that we have that infrastructure around the state. The second component of that model is kind of a pseudo fee for service where we're paying for the actual service, the therapy, the counseling, medication management, et cetera. And the third component is the most creative and innovative that we're working to implement, which is outcomes-based payments, specifically for achieving meaningful but simple outcomes for that priority population that I mentioned. Acute psychiatric adults, corrections-involved adults, and high-needs kids and their families who often encounter the Department of Family Services system. Long-winded way of saying the reason I think this recommendation is suitable here to make it permissive as opposed to required is a similar concept in that base payment bucket that I talked about will already be at work. And we will have the ability to tweak that should we need to make different kinds of subsidy payments for, as Chairman Baldwin mentioned, those more rural and frontier behavioral health centers. So happy to stand for any questions, Mr. Chairman. I'm joined to my left by Franz Fuchs, who's our Chief Policy and Data Analyst, and has really been helping staff this behavioral health redesign with the large stakeholder group. And we're happy to answer any questions.
And so none of these payments happen until after July 4th, 2024. Just it's interesting to have an effective date that long in the future. But
Mr. Chairman, it's interesting, especially for folks who are joining us new. If you look in your statutes in the most recent books or online, you'll see language in this section of statute that is in there, but it has, bold print above it that says this language takes effect July 1st of 2024. So it did the original legislation for redesigning the behavioral health system is certainly in the green books, but with a caveat that none of it takes effect legally until about 18 months from now.
question, Representative Ward.
Thank you, Mr. Chairman. On page 2, starting with line 14, it says the amount of any essential subsidy payment shall be subject to available funding and based on, and then we strike out the prior language, which seems like it would have provided for any care provider within a 35-mile radius, and we replace it with the behavioral health center. Does that mean that those small providers will not be eligible any longer for receiving payments? Why did we make that change?
Go ahead, Director.
Mr. Chairman, Representative Ward, it's a really good question, and I'll try to answer it as best I can. The providers, all of the providers in this system will still be eligible for the full payment model, which includes those base payments. This takes out what was originally put into statute to have a specific formula based on geography that added additional subsidy payments. So through permissive language, we'll still have the ability to design that through policy and rule, but we won't be required to. So those small centers, I'm thinking, for example, you're in Thermopolis or other parts of the state where we have community mental health centers, they'll still certainly be a part of this system. That's not excluding them from that. It's just changing the requirement for these payments for our department to being permissive. So an additional tool we have in the toolbox to change the payment model for certain centers.
Thank you, Mr. Chairman. Can you show me where in this proposed change that those small centers are still eligible?
Mr. Chairman, thank you, Mr. Chairman. Representative Ward. Yes, in the broader, and we have current statute language, and then we have planned for July 1st, 2024 with the redesign. The way it works now is all of our community mental health centers every so often apply through a request for application to be our community mental health centers. They have to meet certain requirements, provide certain array of services, and that won't largely change. The reformed language still contemplates a very similar thing where none of these providers will be excluded. It really just changes the populations that are prioritized and how we pay for them. So I'm not sure if that's answering your question, but happy to elaborate or kick it to Mr. Fuchs if he can add color.
You need to go ahead.
Good morning, Mr. Chairman, members of the committee. My name is Franz Fuchs, Policy Analyst, Department of Health. Mr. Chairman, Representative Ward, I think to your question, those would be defined in the definition of behavioral health center earlier in the statute. It's not in this bill because this bill only tweaks a little section of that statute. But if you were to look at the definition section of that statute, we're still basically making, those providers are defined as behavioral health centers under the statute. And so when you look at the tweak here, what we're doing is the funding still goes to behavioral health centers. We're just making the formula less prescriptive. We're making it defined as based on the service needs as demonstrated by that center, not some formula based on the population and the number of providers within a 35-mile radius. And I can get into why that was pretty complex to calculate, but the main reason that the main change between 16 and 20 is not changing who's eligible for these payments. It's just making the formula less defined in statute and more permissive and flexible.
Good enough. Other questions? Representative Yin.
Thank you, Mr. Chairman, Mr. Fuchs and Director Johansson. So, I remember some of the discussion when we were talking about the original reform bill that we passed a couple of years ago. Maybe just to make it easier for me to help understand it if we have questions on the floor, essentially what we're trying to do here is make it easier to make it less restrictive to provide funding for those more rural areas so they don't get punished because they're not as dense as behavioral health centers in more dense areas.
That be correct, Mr. Director?
Mr. Chairman, thank you. Representative Yin, yes. And to add to that, I would say, if we think about what this reform is trying to achieve, Chairman Baldwin mentioned populations that we do have slipping through the cracks. You know them in your communities with your county attorney's office, your courts, your family services system. Chairman Baldwin mentioned the state hospital. Part of this reform is really to target populations like that cycle in and out of my state hospital to provide more comprehensive community services and also incentivize outcomes for those clients. The issue, Representative Yin, that you bring up is absolutely true, where you're going to have centers in certain parts of the state that won't have as much of that population. And therefore, if we were just overall changing the funding model, you would have, we're trying not to have as many winners and losers just based on population size, because those populations can be so much denser in other areas.
It's Fuchs.
And Mr. Chairman, Representative Yin, just to follow up with a concrete example, this formula kind of created some weird artifacts when we were looking at the number of providers. So for example, if you take Torrington, Torrington would ordinarily be an area that doesn't have too many mental health providers in that, eastern part of the state. But because the prison is there and they employ a lot of behavioral health providers specifically for that prison population, this statute includes this language would include them in the count. And so they wouldn't be getting those essential subsidy payments per this statute based on that random artifact of having a state institution and those providers in that location. Same thing with Albany County with the university has a lot of behavioral health providers by licensure, but may not be practicing. They may be teaching or at the university or doing research. There's just these random artifacts around the state where you can't, all behavioral health providers are not necessarily equal as far as providing services to the population. And so when you write it in statute like this, it just becomes, you get these strange artifacts where certain centers get disadvantaged because of that. That makes sense.
With questions, Representative Clouston.
So thank you, Mr. Chairman. So explaining this, I mean, I like this new formula because it looks like it's need-based depending on how your population's changing, right? Versus just before it was strictly population-based and didn't give us this flexibility to look at which communities maybe have a higher or less need for these services. Is that correct?
Mr. Chairman, Representative Clausen, absolutely couldn't have said it better myself.
Representative Penn.
Thank you, Mr. Chairman. I don't see a fiscal note on this. Is there already an allotted amount of money that we just, that's a cap? This isn't going to change it. It's just changing how we disperse it.
Mr. Chairman, Representative Penn, yes. So the budget is really in 4 units. Budget for community mental health and substance abuse in my agency is in 4 units. For those who want to cross-reference, it's 2506, 2507, 2508, and 2509. Currently, as appropriated, it's about $100 million per biennium. That has changed with money that's been allocated, through CARES Act and ARPA funding in different pockets. But generally in the standard budget, it's about that amount. So that funding amount, Representative Penn, is really in the hands of the legislature. And I think part of this redesign will allow us as we gear towards implementation, especially in that first year or two of implementation, to come back to you all in this committee on how did those budgets need to be tweaked, if at all. But it's capped essentially by the legislature, by our budget.
Okay, Representative Hornock. Thank you, Mr. Chairman. So it seems to me that, and help me because I could be reading this wrong, but it seems to me like the original language about the population and geography of the area served takes into account making sure that the rural clinics do get a little, it might be a smaller amount or whatever, but they do get something for providing these services. Whereas the new language would allow a large provider to possibly essentially gobble up all of the money associated with this system, with these payments. Help me understand that, because I'm a little worried that now you're going to have one place that kind of gobbles up all the money, and the way the statute's written, it's only that much money that's there for these services. So maybe one of these small communities gets left out because, well, sorry, it's all gone because this large community gobbled it all up, and it's not, even though it's not spread out equally, it's spread out some to everybody the way the original language was kind of structured. Go ahead, Director.
Mr. Chairman, Representative Hornock, again, a really good question. And we're seeing in this bill only part of the reform statute. So if you go back and look at the behavioral health redesign, the behavioral health centers as they're defined, as Mr. Fuchs mentioned, and what's directed, as I mentioned before, I think that problem that you're mentioning is solved by what we're directed to do in that kind of 3-pronged payment model, which is base payments, then payment for services, then outcomes-based payments. So it's our intention, certainly, and I think the mission articulated in the broader statute, that we want to avoid the problem you're talking about. This should not be for our population centers, because that's not where the need scales down to your lower populated communities. And I think that payment model that I just mentioned, especially on the base payment side, accounts for that. This was a small component, an addition to the behavioral health reform to require the department to have additional calculated subsidy payments. And now changing it from required to permissive, I think gives us the flexibility not only to solve the problem that you're talking about, but as Mr. Fuchs mentioned, if we just calculated by geography and the number of providers in the 35-mile radius, in the data that we have to use, that we can be transparent about with you all, you get those weird nuances where certain pockets in other parts of the state look dramatically different than others, but not because they have more providers or they have more ability to provide service, just because of, facilities being there or the university being there. So again, I might not be answering your question well, but I think in the broader reform statute where these items are directed for how we pay, we can absolutely account for that problem.
Okay, other questions for the department? Mr. Fuchs, go ahead.
Sorry, Mr. Chairman. Mr. Chairman, Representative Hornock, I just wanted to offer another concrete example. The town of Glen Rock is a good example. They have a community mental health center. They're very, very small, kind of branch location. By this formula, Glen Rock is within 35 miles of both Casper and Douglas. And so all those providers in those two towns would count towards their that formula. So that's another example of just like Torrington, where very, very small center being disadvantaged by this specific formula just because of an artifact of geography. So that's really the real intent here is just to make it more flexible so we can take that into account and say, okay, well, yes, Glen Rock is technically 35 miles within those two big population centers, but it's isolated in its own way. And those, we need to consider those service needs on a unique, case by case type basis.
Representative Ward?
Thank you, Mr. Chairman. I have a question for the good Senator Baldwin, if we can bring him back up or I can just wait.
If you wouldn't mind waiting for just a bit, then we'll bring him. Actually, we could probably bring Representative Larson up next since he joined the room. I don't know if that would be, it's Representative Larson. You can throw all sorts of fun questions at him. And if he can't get him, we'll get Senator Baldwin back up here. But Representative Larson, anything to add? I know you missed part of the discussion, but you just tell us it's a good bill with your name on it. We'll believe you.
It does. And I'm sure that much of this history has been already presented to you, but when we done the behavioral health redesign, as I'm sure you all understand from previous conversation, trying to figure out how do we keep these community mental health centers in rural areas whole enough that they can provide the services. And we contemplated, what's the right model to use. So we kind of come up with this idea, if there's no other services within 35 miles. And we stuck with that as we created the subcommittee to implement the behavioral health redesign with the community mental health centers. We went through that over a couple of years, piece by piece. And it was towards the end, the community mental health centers then come to us and said, in one of our last meetings, they says, time out. We get this. We don't need that 35-mile radius or anything. If you would, in the language was theirs, they feel comfortable with doing it with all the effort that's gone into it. That's why we brought this. And so Senator Baldwin and I chaired the committee with the community mental health centers and Department of Health and Department of Family Service and Department of Corrections. Then they says we can address that by just seeing what the needs are as demonstrated by the centers has already been pointed out. So this is just a further refinement of that effort that started.
Representative Ward, I don't know if you want to try to throw that question at Representative Larson while he's here. Go ahead.
Thank you, Mr. Chairman. So that it didn't pass unanimously in the Senate and that there was some opposition even in committee. And I was wondering if you could explain what the opposition was.
That would have to come to my good colleague from the Senate. Mr. Chairman.
Yep. Senator Baldwin, welcome back.
Thank you. Thank you very much for that question. That's always a question. When I read through bills, I always read who said no, who said aye. The opposition on that bill chiefly came from the two folks, I believe it was two, not no, or one, who were there when we did the behavioral health remodel or, revisiting it. And they originally were in favor, but in general, anything comes up to have to do with the behavioral health remodel, they do oppose. So it's not that they're opposed to this tweak per se, they're opposed to the entire model. So as they voted no when we did that last year, they continue to vote no, and I suspect that they will vote no as we move forward with any other tweaks. Maybe I can get them to vote aye on something, but that was the reason.
While you're here, I mean, this bill doesn't attack the entire model, but would you say this actually streamlines the model? If these payments are gonna happen, this at least gives you a may and it clarifies. I mean, in some ways, this is more efficient in spending dollars and is actually probably a benefit. If you can't take away the model, this is more fiscally conservative and targeted.
And you use the right word, and it makes it more efficient. We're getting people that were, as we said earlier, slipping through the cracks. This makes it more efficient, those people, and in the end, probably saves our system and saves our Department of Health and the state, the citizens, et cetera, money, because we're actually more effectively treating those that may have somehow fallen through the system previously.
Mr. Chairman.
Representative Larson.
And this bill gives more flexibility to address the needs of the respective community mental health centers as they are able to demonstrate that they perhaps may need subsidies, or how do we get there? With our initial draft, which arguably we just didn't know how to determine within what radius or what parameters you use. And then so you got into, does that mean schools have psychologists or professionals? Does that include them? Does it include, who all does it include? But it was the best attempt that we had. And then when the community mental health centers and the subcommittee finally got through all of the allocations and how we pay for services under this behavioral health redesign, where we prioritize these populations, they says, well, we probably then could, rather than having these finite points scattered around to define what qualifies for a reimbursement, if the community mental health center could demonstrate that there was a need based on population or services in the area, that seems to be more reasonable approach, and certainly gives the department and the providers much more flexibility.
All right, let's see if there's anybody else, public comment. You look excited to join us this morning, Ms. Somerville.
Morning, Mr. Chairman. I'm always excited to come join you early in the morning. Andy Somerville, Executive Director for the Wyoming Association of Mental Health and Substance Abuse Centers. We are here to ask for your support on this bill. As has been discussed, I won't belabor the point, but there's been a lot of work that's gone on over the last couple of years, and specific to this bill over this last year. And how to put all of these pieces to this major redesign process in place. As you can imagine, how you pay providers is incredibly important in determining how we keep services open across the state. I guess I want to start by saying that this request from your community mental health centers is unanimous. From our smallest community mental health center to our largest, they were all at the table, and this request comes from all of them. It became clear while we were spending many hours, especially with the director, Mr. Fuchs, trying to figure out how to make that geographical formula work that's in the bill, that it just didn't work. I myself personally spent several days pulling mental health licensures and trying to type and cross employers and categorize what is across the state. That in itself is incredibly burdensome, but also, as illustrated by Mr. Fuchs, we quickly found that there were a lot of problems and issues that we couldn't work out very well with this particular formula. We do think the flexibility is important as we move forward. Each county that is served by a community mental health center really needs the ability to be able to demonstrate if there's a service need or a change, or if they're incurring any issues or anything along those lines in terms of trying to keep services on the ground in those counties. This bill allows them the flexibility to do that. So we would ask for your support. Mr. Chairman, I'd be happy to answer any questions.
Questions for WAMSAC? Seeing none.
Thank you.
Anyone else here to testify in Senate File 8? Department of Health row in the back? Nope, not this one. No, we're on the hospitals. Henderson, Representative Conrad, Representative Henderson, not this bill. All right, seeing no further public comment, we'll close public comment. Committee, what's your pleasure on Senate File 8?
Move the bill.
Moved by Chadwick, seconded by O'Hearn. Discussion or amendments, committee? Don't need to go page by page because it's a two-page bill. Representative Yin.
Mr. Chairman, I thought it was interesting to hear from the bringer of the bill that those that were opposed to the reform are still opposed to this, because I think I agree with you, Mr. Chairman, as someone who did vote against the behavioral health reform. I think this makes it better. So yeah, I think this is a good bill.
I think those of us yesterday in the House and Speaker Summers got up on a bill and said, you know, we don't always get it right, but we try to get good legislation out there. And sometimes we come back and have to tweak it and fix it to make it what we want. This is a good example. Other discussion? Seeing none and question being called. Marilyn, if you'd call the roll on Senate File 8.
Representative Chadwick.
Aye.
Representative Klauskin.
Aye.
Representative Horner.
Aye.
Representative O'Hearn.
Aye.
Representative Penn.
Aye.
Representative Trujillo.
Aye.
Representative Ward.
Aye.
Representative Yin.
Aye.
Chairman Swanitzer. Thank you.
Representative Larson, you carrying this on the floor? Get Representative Walters to do it. All right, I'll give that to Representative Larson on the floor. Representative Trujillo, you want 9 or 11 next?
Let's just go.
All right, Senate File 9, Medicaid coverage licensed pharmacist. Please welcome back Senator Baldwin. And I see Representative Larson is also on this bill.
It's good to see you again, committee.
It's going to be
Been such a long
an
time.
exciting interim for all of us. Go ahead.
The seat's still warm. Okay. Committee, this is Senate File 9, titled Medicaid Coverage Licensed Pharmacist. First of all, the basic concept for this. Number one, it doesn't add anybody to the Medicaid rules. It doesn't expand the services or change the scope of practice for pharmacists. What this bill does is when an insurance company, to any insurance company, they all look to the Medicaid providers list for when they talk about reimbursement. And then Representative Penn can know a little bit about this. They go to that list and that's who they decide who they're going to pay and who they're not. There's a few groups right now, and I would use advanced nurse practitioners, PAs. At one time, not all that long ago, were not on that list. And so they were not reimbursed. Eventually we get things added to that list and they're able to be reimbursed. Not so much by Medicaid, but by the other insurance companies who look to Medicaid. And the folks from the Department of Health can tell you those insurance companies look to Medicare and Medicaid for a lot of things, for reimbursement rates, which is unfortunate because Medicare and Medicaid reimbursement rates are quite low. And if you haven't heard that yet on this committee, you will hear that. This is another area that they look like on how they decide who they're going to reimburse. So when that insurance company, if you are prescribed to X insurance company and you go to a pharmacist and they do your vaccinations, for instance, they will not be able to bill that to the insurance. You would have to pay that individually. And that's a lack. And as pharmacists have expanded their practices over the years, they really haven't, they're just practicing what they've been trained to do. Now they're just doing it. And COVID amplified that. You know, everybody couldn't get into their family provider to have a vaccination, to have a COVID test, to have a flu test, to do whatever things that pharmacists do, and they've done for a long time. And pharmacists are one of our most underrated and underutilized members of the healthcare team. What this bill aims to do is to get them on that list so they can be reimbursed for those things they're due. We could go through a whole list of what pharmacists do. And I mentioned vaccinations. I mentioned testing. They do so much educational work. I depend on my pharmacist, and I believe most providers do. I may give a prescription and I may not know what that person is taking. And the pharmacist will call me and say, are you sure you want them to be on this? Because they know they've got that communication. They fill all those prescriptions. That's just one example. And they can teach the patient all the different things that a medication does, things that a provider doesn't always have the time to do, particularly since we have to do the electronic medical record, et cetera. Time becomes very valuable. So pharmacists fill a huge slot. And they're
Chairman
doing a lot
Baldwin, I
of
just
work.
want to make sure I have your testimony. Pharmacists do really good things.
That would be a good
We
synopsis.
like our pharmacists.
I don't know if there's any pharmacists behind me or not. I didn't look, but they'll tell you the same thing.
If they give an award for legislator of the year, I'm guessing you're getting it.
Oh,
Um,
which is beside the point, but,
Committee,
but
any questions for Senator Baldwin? Representative Ward.
Thank you, Mr. Chairman. So the current presidential administration has discussed declaring an abortion public health emergency and is now forcing pharmacies to distribute the abortion pill. Could this coverage be used to provide government funding for the abortion pill?
Senator Baldwin, if you know.
Mr. Chairman, I would have difficulty, and actually the pharmacist may be better fit to answer that question. I honestly don't know. I can't really answer that question effectively. It's a better question for the pharmacist.
Other questions, committee? Seeing none? Don't go too far. Department? Director Johansson, welcome back. Same seat too. Dr. Cooper, come on forward as well. Ms. Stahl, we're not going to see you much more, so any opportunity you want to come forward, I'm always happy to have you. Not yet? All right, welcome, Director.
Thank you, Mr. Chairman. Again, Stefan Johansson with the Department of Health. I was going to be extremely brief and say I'll stand for any questions. We don't have any major concerns with this bill. But if I may, I can address Representative Ward's question that in the Medicaid world, that payment for that type of service or pharmacy for abortion would not be allowed currently. So I think the issue might be more pertinent to commercial plans or private plans, but not in the Medicaid world.
Representative Yen.
Mr. Chairman, just to verify, Medicaid funds can't be used for any elective abortions. Is that correct?
Director
Mr.
Johansson, if you
Chairman,
know.
Representative Yen, that's true based on the Hyde Amendment. And I believe we have language that mirrors that in state statute as well. Our coverage of any sort of abortion services comes from basically emergency medical necessity needs, life of the mother, that type of thing.
Dr. Cooper, welcome. Anything else to add in the bill?
Good morning, Mr. Chairman, members of the committee. My name is Corey Cooper. I'm the Pharmacy Program Manager for Wyoming Medicaid. Just for informational purposes, only what we would do on the Medicaid side is do a state plan amendment with the federal government. So that's just our agreement with CMS of how we're going to run our program and who is allowed to bill. So we would do a state plan amendment, adding pharmacists. And you will note also with this one that there is no fiscal note. And the reason for that is because we did the calculations, looked at the uptake of these services by pharmacists in states where they have already been added as providers for Medicaid. And we feel that that cost is absorbable and the potential offsets from having pharmacists able to provide these services and then avoid having to go to the doctor or heaven forbid having a hospital visit where for an adverse drug event or something like that. Basically even each other out. So Medicaid will be able to absorb the cost of adding pharmacists without the fiscal note. With that, I'll stand for questions.
Questions for the department? Question, Representative Klauston.
Thank you, Mr. Chair. Director Johansson, at once in a while, we spend a little time in the legislature talking about abortion. So could you tell me what statute that is? That'd be helpful for all of us to look at.
Mr. Chairman, Representative
know?
Clausen, I don't have the number off the top of my head. I could get that to you though. I believe it's mirrored in Title 42, but I'd have to double check.
Other questions for the department? Representative Hornock, and then we'll go back to Representative Penn.
Thank you, Mr. Chairman. This does say the professional services of a licensed pharmacist. Can you expand as much as possible on what those professional services are?
Dr. Cooper.
Mr. Chairman, Representative Hornock, pharmacists are trained for a minimum of 6 years, and the base degree that pharmacists can graduate from school with at this point is a Doctor of Pharmacy degree. Highly clinically trained professionals able to do what we expect would be billed under this permission would be mostly medication therapy management. So an actual in-depth consultation with the patient, maximizing their medication utilization, some additional work with their providers to coordinate their care and optimize their drug therapy. And so that would be an appointment, 15 or 30 minutes of working directly with the patient. Without this bill and without the addition of pharmacists, quite frankly, our pharmacists don't have time if they're not getting reimbursed for those cognitive services. Additionally, as was already mentioned by the sponsor of the bill, vaccinations, we in Medicaid, we can reimburse pharmacies for the vaccine itself, but we cannot reimburse the pharmacy for the pharmacist's time to actually administer the vaccine.
Okay, Representative Penn?
Thank you, Mr. Chairman. So I have a hard time understanding how this doesn't have an increased fiscal note. It sounds to me like we're going to be billing additionally. I mean, you did mention that this would be an offset because instead of going to the doctor, I think is what you said, then they would be able to get this counseling from the pharmacist. But in my mind, it seems like at some point they would have already had to have gone to the doctor to get the prescription in the first place. So that charge is already occurring. It's not going to eliminate that charge. This seems like this is going to be an additional charge for the pharmacist to then say, I handed them this medication and I talked to them about it. So could you help me understand how you're coming to this fiscal note?
Sure, Dr. Cooper.
Mr. Chairman, Representative Penn. So the services we're talking about are not necessarily performed at the time of dispensation of a single prescription. And I think obviously any patient probably sees their pharmacist more often than they see their prescriber. Because if they're on a monthly refill schedule, they're seeing their prescriber once maybe for the entire year. There are enough refills provided, so they see their prescriber once and then they see their pharmacist every time they pick up that prescription. That's not to say that a medication therapy management visit would be every single month, but it provides additional access to care for patients who are already in the community and already seeing their pharmacist on a pretty regular basis because they're going in to pick up their medications. So the reason that we calculated we can absorb the cost and therefore didn't add a fiscal note on top is mostly based on calculations from states like Missouri, who have had pharmacists as providers in their Medicaid agency for over a decade now. And the uptake of those services, the frequency with which the pharmacists actually bill and the Medicaid program reimburses those is not large. It's honestly not large. And their provider population is oodly gobs larger than ours. That's a technical term. And oodly gobs. And their uptake just really isn't that large. And so we, when we calculated that as a percentage of what we, and the reimbursement cost for the services that we expect to be billed, it just really was absorbable by the Medicaid agency and our current budget.
Okay, Representative Hornock again.
Thank you, Mr. Chairman. So I am having some difficulty understanding this. Every time I have been to a pharmacist, in order to get any services from them, I whip out my insurance card, I whip out my credit card. Anything I get from them is paid for by me or by insurance, or I imagine by Medicaid. So I guess, first of all, I'm not understanding why the pharmacist services wouldn't already be paid for completely when they render service. And then also, there's a gap. I don't understand how, in order to be eligible for Medicaid, you have to meet certain income requirements. So if somebody comes in to see a pharmacist, even for something like medical therapy management, are they then filling out paperwork that verifies their income level? You know, how do you, are we saying any pharmacist, anything the pharmacist would do will be covered under Medicaid? You know, where's the gap there? I don't really understand this concept of adding pharmacists to something that seems to me like they always receive payment for, generally from one side of the counter. Thank you.
Director Johansson.
Mr. Chairman, Representative Warnock, if I can answer that. So this does not open up the door for Medicaid to be a payer for all pharmacy services. This is strictly for the Medicaid population, meaning that as Dr. Cooper mentioned before, we have certain populations, as you mentioned, and you can't be on Medicaid just by being low income. You have to meet a categorical condition currently, since we are a non-expansion state. But we have populations that are covered by Medicaid, and then to access those services and care, we have certain provider types that are covered by Medicaid to provide services. This bill for adding pharmacists to who can bill Medicaid for professional services is just in the Medicaid plan. So it wouldn't apply to commercial insurance or private pay or anything like that. And then to your question about if a Medicaid patient comes in and fills a prescription, isn't that service already covered and paid for? The answer is yes and no. The medication itself is covered and paid for, and the pharmacy is reimbursed for that. The professional service of the pharmacist, as Dr. Cooper mentioned, which isn't highly voluminous, but something that we've all experienced, and especially more so in the past several years, where pharmacists in commercial plans in the private market are able to do more, able to administer vaccines, able to consult with patients on medication management, certainly not from a physician perspective, which is the or practitioner perspective, which is the original prescriber, but professional services more in that consultation and service delivery that's really outside of what you typically see in a patient physician or patient provider relationship. So this is not expansive. I want to be very clear. This does not do anything to expand the breadth of what Medicaid does for the broader market or broader healthcare services, very specific to the Medicaid population, and adding a provider type to who can bill Medicaid. And as we've just discussed with Representative Penn's question, these are not highly voluminous services. So we believe that it's absorbable, and the benefit, especially for patients on regular medications who might not see a provider very often. Other states, and certainly we see it in Wyoming, you do see potential medication issues, which leads someone to go to the emergency room or go to the hospital. And I think through this type of service, some of that can be avoided and potentially offset the cost.
Representative Penn, question?
Thank you, Mr. Chairman. So I'm having a hard time understanding how you're saying that it's not going to happen very much. It's absorbable. So why do we need to do this?
Mr. Chairman, Representative Penn, because currently the pharmacists are not allowed to bill. There's unreimbursed services that are being provided. It's not dissimilar from, I remember years ago, and I'll give an example in the Title 25 statute, where you have a per diem that's paid to the hospital that's caring for a psychiatric patient. And then you also, the provider can bill for professional services. So a private physician that comes in and consults on something, those things get added or not over the years. This is something where licensed pharmacists right now are not a provider type that can bill directly in Medicaid. Those services of filling a prescription, having the prescription reimbursed to the pharmacy is absolutely covered under the pharmacy program, but just not the professional service.
Okay. Any other questions for the department?
Mr. Chairman, I think Dr. Cooper
Dr.
had.
Cooper, welcome.
Mr. Chairman and Representative Penn and Representative Hornock, if I could add just to what Director Johansson already said, as an example, to provide an example, which maybe makes this easier to understand. Someone personally close to me recently had a health crisis and high clot burden in both lungs, a saddle embolism. So really a health crisis. And after hospitalization, because they're personally close to me, I was able to sit down with that person in their home and say, and I'm not suggesting this would happen in anyone's home, but because it was a personal contact, sit down with that person and go through their medication list, what any herbals, supplements that they were taking, their entire medication regimen, and say, given the conditions caused by this health crisis and things that we have to consider now, I would recommend taking these things out, talk to your prescriber on these other things, and sort of coordinate care for that person. And I think that's the kind of interaction that we're looking to allow pharmacists to do as a part of their practice. It's certainly within their scope of practice. It's certainly within their scope of training. And it's something that having a health crisis and being hospitalized, seeing a different doctor every day of that hospitalization, and then seeing several specialists after that. The coordination of care doesn't necessarily happen, and taking the time to actually have a deep conversation with that person about all of their medications as a whole, what was helpful. And of course, I wouldn't ask to be reimbursed for that because it was someone who was personally close to me, but someone who is doing that and providing those cognitive services on a day-to-day basis in their practice. It's helpful for them to be able to bill for that. It's helpful for them because they're taking time from doing the rest of their work, which is dispensing a product, but they're certainly trained to do more than count by fives. And we'd like to acknowledge that. And also, as Senator Baldwin mentioned, part of the reason that this is coming up is because commercial insurers look to Medicaid and Medicare and their provider lists in order to decide who they will reimburse. So while the impact to us is for Medicaid patients only, the intent is to give those commercial insurers a chance to reimburse pharmacists for their cognitive services as well.
Okay, question, follow-up, Representative Penn? Go ahead.
Thank you, Mr. Chairman. Has the medical or the Board of Medicine or the doctor side weighed in on this? I mean, what you were just saying sounds a little bit like that could, I mean, it's a fine line between, and I'm not saying that pharmacists aren't qualified to discuss medications. When you're talking about going over medication lists and telling them that maybe they should stop these medications or things like that, that seems a little concerning. And I'm just wondering if the medical side has weighed in on their concerns about if there's going to be overlap, or, at what point should a patient be seeing their doctor, and or are they going to start coming to the pharmacist as their doctor?
Dr. Cooper, you want to?
Mr.
Answer that.
Chairman, Representative Penn, I haven't had a specific conversation with the Board of Medicine, and certainly that's an option. I do want to point out that I was very careful in my testimony to say that even when talking to someone who is personally close to me, I never said, just stop this. And we're trained as pharmacists not to do that. It's not within the scope of our practice to stop someone's med without their prescriber knowing about it. The point of the cognitive services and medication therapy management is absolutely to facilitate coordination of care between the multiple providers that may be prescribing to a patient, and making sure that the medication therapy is optimized for a patient. No pharmacist I know would tell a patient to just to stop taking their medication.
Other questions? You good? Representative Hornak, give another one. Go ahead.
Thank you, Mr. Chairman. So this seems to me like it would add a lot of liability for the pharmacists because they are providing an extension of care beyond what people are used to. The extension of care would be what somebody typically goes to a healthcare provider to talk about. So I'm curious if there is a concern with the liability and what type of insurance a pharmacist carries now, would they be covered? Is there a issue as well with, I understand that people sue their healthcare providers for whatever reason. I don't know if that is this allowed as well with a pharmacist or something because of what we're talking about here. I don't know. There just seems to be some real liability issues on this.
Dr. Cooper?
Mr. Chairman, Representative Hornak, many pharmacists and many pharmacy corporations who have, large chains of pharmacies do carry malpractice insurance for either for themselves as a pharmacist or corporations for their pharmacists who work for them. Because yes, there is liability in being a pharmacist. There's already a responsibility that pharmacists carry to ensure that patients are taken care of as well as possible. And that liability just exists in the medical realm. And so malpractice insurance is a pretty common thing for pharmacists.
Okay, other questions for the department? Seeing none, thank you. Senator Baldwin, if you want to answer, jump in on that one question, go ahead.
Yeah, just, excuse me, I lost my voice before. Just a quick answer to Representative Penn's question. In the interim, when we presented this bill, when this bill was drafted, the Board of Medicine and the Board of Nursing both did weigh in on this bill in support. And I guess the issue being is that it's not an expansion of the pharmacist role at all. This all fits within their practice act if you were to go to their statutes. We're not expanding that. We're not changing anything. It's all stuff that they do now. They're just not able to bill for. And this opens up the private insurers. That was the main intent of the bill, but the Board of Medicine and the Board of Nursing both did weigh in support.
Thanks. Any other legislator, Representative Larson, Zwanitzer, Henderson, anybody testifying this one? Okay, pharmacists. Welcome, Pharmacy Association. Floor is yours.
Good morning, Chairman, Committee. I'm Melinda Carroll. I am a doctor of pharmacy as well. I would just like to say that pharmacists are very highly trained. They receive as much classroom clinical instruction as a medical doctor. Again, we are trained to do these services, and it is more than medication therapy management. We do testing, COVID testing, flu testing. I myself, at my practice, I am able to do cholesterol panels, A1Cs, various things that, yes, you would typically think of at your provider's office. However, in the state of Wyoming, we do have a healthcare shortage, and we're well aware of that. Pharmacists are very accessible to the public. And as for payment of these services, to address Representative Hornock's question, do we get paid for it? So that's a tricky question. So you can submit a claim to the insurance and they get to decide whether they pay for it or not. You have already provided that service, and they will come back and say, because you are not a recognized provider, we are not paying for that service. So I can tell you that there were several pharmacies over the last couple years that did all of that testing for free. That was all not reimbursed because they are not recognized as providers. And I would argue that we are healthcare providers. We're an integral part of the healthcare team. We do coordinate care. We do reach out to providers to optimize therapies, in conjunction with them. And we have very close patient relationships. So we care for those patients, and truly that's why those services we just provide because we care for those patients and want to see the best outcomes for them. And really that's what we are looking for. If it continues down the path that it does, unfortunately, pharmacies will not be able to continue to absorb the costs of providing these services for free. And that would be a detriment to the healthcare system as a whole. It would be a detriment to the patients for sure. And then also to the healthcare providers that would not be able to rely on the pharmacist as the medication expert, because truly that's what a pharmacist is a medication expert. Our practice has expanded quite a bit beyond that, but truly that is a role that the pharmacist fills. With that, I stand for questions.
So not trying to put you on the spot. You didn't mention the association. Does the association have a position on the bill, or are you speaking as an independent, just pharmacist?
Chairman, yes, the association is in support of the bill and would ask you to support the bill for pharmacists across the state.
Questions for the pharmacist? Seeing none. Thank you for being here. Anyone else in the room wish to testify on House Bill 9? Hospitals, no? All right, we'll close public comment on House Bill 9. Committee, what's your pleasure? Moved by O'Hearn, seconded by Clouston. Sure. Okay. Was it Chad?
Starts with a C.
Sometimes you're looking one way and yep. We'll get the class anyway. Representative Ward.
Like to propose an amendment that says no Wyoming Medicaid fund shall be used to cause or procure chemical abortions in the state of Wyoming.
Before I ask for a second, maybe tell me where you'd like that inserted. It might just be, you'd be like a separate provision.
It can be inserted as a separate provision at the end.
Somewhere in 42.4.103, or perhaps just a separate section,
Like
wherever
separate.
LSO finds it's best suited. Would that maybe,
That's fine.
okay, is there a second to that amendment? Second by Penn, discussion on that amendment, Representative Young.
Thank you, Mr. Chairman. So I looked up the statutory citation. It's 35.6.117. Use of appropriated funds for abortions prohibited. So there are no public funds that go to this, except in the case of what the director said, if there was a case of incest, sexual assault, or the life of the woman.
Just checking if that
So-
satisfies your Representative Ward, or
So
go ahead, Representative Young.
thank you, Mr. Chairman. My guess is that they will take this out on the Senate side in conference, because it's unnecessary since it's the same as the language that we already have.
Normally don't comment about what the other body might do, but Representative Yin, it might be necessary. So the language of that amendment, one more time, Representative Ward. Just make sure the secretary has it, and then wherever LSO wants to put it in, probably in Title 35, but go ahead, just so Maryland has it.
No Wyoming Medicaid funds shall be used to cause or procure chemical abortions in the state of Wyoming.
Committee discussion on the amendment. My personal thought is I'm not sure it fits exactly within the scope of the bill on this one, but any other discussion? All those in favor of the amendment, say aye. Opposed, say no.
No.
Show of hands. All those in favor, if you raise your hand. 2, 3, 4, 5. That amendment is passed. Other discussion or amendments on the bill? Representative Penn.
So, I'm struggling with this one because I think pharmacists do a wonderful thing and I appreciate what they do. If this wasn't about Medicaid first, I would be an aye vote on this. My concern is I still have questions about the actual fiscal impact to Medicaid and trying to be a responsible steward of taxpayer dollars. I feel like I need more fiscal information on how much this is actually going to happen. We've been told that it will likely happen little, but in order to be an aye vote on this, I would need some more information on what's reality there.
Bill does pass. I'm sure Dr. Cooper and the fourth floor of Hirschler West would be happy to have you come up anytime. Representative Clouston.
Thank you, Mr. Chair. My hometown, we've lost now our last small pharmacy. Pharmacy, which is unfortunate, right? Because every time I go in there, when I talk to them, they talk to me about how my medications, work together or work against each other. And I think in the long run, having more time with the pharmacist actually probably cuts down healthcare in Wyoming, because it's avoiding some problems and solving some problems that, maybe you're not able to get into your provider, or sometimes you go to an urgent care and you get, one provider one day, next time you go in, you get somebody else the other time. And the consistency in my care has always been my small town pharmacist. So I think we need to support them, and I can see this actually saving long-term healthcare dollars.
Question being called, Representative Hornock, discussion.
Yeah, thanks, Mr. Chairman. I'm sensitive to the needs of pharmacists. But I think in every industry, there are things that that people in those industries do without being reimbursed for it, without payment. So it seems to me like this opens the door to every time a pharmacist gives their opinion about something, they can bill for, Medicaid reimbursement on this, if in my industry, if every time somebody asked me to give them my opinion of what to do with that trim or how much that door costs to replace, if I could bill for that's going a little bit overboard. So I just think we're getting down into the weeds, going a little far with all of this. Thanks.
That's how my attorney works, but maybe not other professions. Go ahead, Representative Ward.
Thank you, Mr. Chairman. You won't be surprised that I will be a no vote on this. I view this as an incremental expansion of Medicaid in Wyoming, and that's not the proper role of government. So, thanks.
Even with that exciting amendment, still no, huh? Okay, Representative Trujillo.
In my district, I would see this as very beneficial. I always see long lines at my grocery store, and I feel that it helps my community when they go in and they're trying to buy the little groceries that they get, and they can actually stop and talk to their pharmacist and say, I think I'm feeling a little extra dizzy today. Do you think it could be this medication? So it's going to be very beneficial to my community.
Reverend Chadwick.
Thank you, Mr. Chairman. As I view this bill, it would appear to just simply shift dollars from one provider to another provider as per the fiscal note. Pretty simple. Thank you.
Okay, with that question, Marilyn, would you call the roll on Senate File 9?
Representative Chadwick. Representative Klauston.
Aye.
Representative Hornock.
No.
Representative O'Hearn.
Aye.
Representative Penn.
No.
Representative Trujillo.
Aye.
Representative Ward.
No.
Representative Yen.
Aye.
Chairman Swanitzer.
Aye.
The bill passes 6 ayes, 3 noes.
Representative Larson, your name's on this bill. Do you want this one as well? I'll be happy to help you. It's going to be a busy floor season Monday. All right, committee, with that, we're on to Senate File 11. Welcome back, Senator Baldwin.
Thank you again.
You're with us all interim too. It's going to be great.
Don't get used to this.
Senate File 11 is Cancer Early Detection Amendments, which is an interim committee bill. And as you're well aware, none of us were on the interim committee. So if you would update us on Senate File 11.
Absolutely. Thank you, Mr. Chairman. I bring you Senate File 11. Again, and I apologize for referring to you so much, Representative Penn, but you will be more familiar with this than anyone in the group. Cancer guidelines periodically change. Most recently, the screening recommendations for those with for colonoscopy changed from 50 years of age to 45 years of age. Our statutes for the colonoscopy program, which is a program, it has a set fund, it has a cap. We're not changing that cap at all. The recommendations are in there. If you look on page 2, about line 8, I believe, eligibility should be restricted to individuals who are at least 50 years old and who have become eligible for the federal Medicare program. With the shift to 45 years, this was no longer meeting the recommendations of the national cancer recommendations. So a decision was made by the interim committee to change this. Some of the questions you'll ask, and some of the folks behind me will answer some of these. This is a capped fund. We're not increasing the fund at all. What happens when we use up that money? And they can tell you how many people traditionally have used that through the years. Once we've reached that limit, they then form a waiting list. And I believe, and they can tell you more, but that's been reached at least once that we reached that waiting list. The other part of the bill is that rather than giving out a voucher for the colonoscopies, this shifts to a reimbursement for the colonoscopies. And I would be preaching to the choir, but colonoscopies are super important. They catch colon cancers early when they're treatable. It's unfortunately one of the leading causes of death. And we'd rather it was not a cause of death at all if we could catch them all. Unfortunately, they're stubborn people like me who don't go get their colonoscopies when they should. I don't listen to my providers like Representative Yens. Go get it done. And I say, nah, doesn't sound like fun. And there's other methods too. Some of the others behind me that don't involve a colonoscopy. There's other methods of detection as well. But the simple file or the aim of this bill is to just change up that statute that we have, make it available for those who are now recommended at 45 years of age, and make a couple other adjustments like the voucher to a reimbursement program. Pretty straightforward bill. It doesn't change a lot. It just brings us more up to date with what's actually happening in the real world. With that, I would stand for any questions.
Questions for Senator Baldwin, Representative Clouston.
Thank you, Mr. Chair. Is there any anticipation that being reimbursement versus voucher, do you think less people will do it? I mean, I'm thinking of somebody who doesn't maybe have the money to pay it up front. And then how long does it take to get the voucher or get the reimbursement versus the voucher? Thank you.
Thank you, Mr. Chairman. Representative, I'll make you a Senator Clausen for the day. I'm sorry. It's in my vocabulary. We talked about that briefly and actually the folks from the department may be able to answer that better. I would suggest that maybe it will have an effect. I believe that we decided that it would likely not have an effect, but because you could work out, payment options or things, but they can address that better than I can.
Seeing no other questions. Oh, Representative Ward.
Thank you, Mr. Chairman. On page 2, line 13, it says the program shall only pay expenses not covered by insurance for persons who are underinsured. That seems like an addition that wasn't there before. Are we expanding that the government of Wyoming is now paying for? Explain to me what that means.
Go ahead.
Mr. Chairman, Representative Ward, I almost said Senator Ward again. I apologize. And that's actually a change that we made to clarify the language because the language before was a little bit cloudy. And it actually, no, it does not change. We're not paying for any insurance. This doesn't change the levels of who's paid for and who's not. And I don't have the original bill in front of me, but that change of language was to make some somewhat ambiguous language. We corrected that. So the underinsured would be those whose, insurance doesn't pay or they pay $10 for a colonoscopy versus the real cost of the colonoscopy, which according to the department, there's not a lot. If an insurance pays for it, they pay for it. And most insurances do pay for the screening colonoscopy.
Okay. Other questions? Seeing none. Other legislators on this bill, Representative Henderson, I believe it was your predecessor in your district who brought this program to the legislature. I've been here long enough. I remember who brought everything. Department, welcome back.
Thank you, Mr. Chairman. Good to see you again. Stefan Johansson with the Department of Health, joined to my left by Star Jones, who's the administrator of our integrated cancer program. And can answer some of the questions that were brought up. Just generally, again, this is more of a cleanup bill that we have folks that should be or could be getting these screenings and avoiding costly care down the road that by the statute language now would not be eligible based on their age. The reason that you see the language on page 2 that you do is so really the interim committee discussed if the recommendations change again, go back up to 50 or go down to 40. Does the legislature need to come back and keep tweaking the statute, or should we just reference the national guidelines, which is what you see here? Mr. Chairman, if it's okay, I'll hand it over to Ms. Jones. I think there were a couple of specific questions around reimbursement that Representative Clouston asked that we can certainly address.
Okay, Ms. Jones, good to see you again. Welcome to Labor Health.
Good morning. Thank you, Mr. Chairman, members of the committee. In reference to Representative Clouston's question regarding reimbursement, or was that? Okay, perfect. So previously the program provided a voucher to the patient in the mail, and they would take that to their surgery center or their provider, and then the provider would mail that to the program for reimbursement. And instead, 2017, the program began working with Wyoming Medicaid to do electronic billing reimbursement. So the reimbursement is directly to the patient, not the to the provider and not the patient. The patient does not have to pay any upfront costs. This just updates the statute to our current method of reimbursing providers. And then in reference to Representative Ward's question regarding uninsured individuals. So this program does provide funding for Wyoming residents who are at or below 250% of the federal poverty level, who are uninsured or underinsured, meaning that they have an out-of-pocket expense that they cannot afford. So if you go in for any kind of symptoms, your colonoscopy is no longer considered a screening colonoscopy. It's considered a diagnostic, which means your out-of-pocket expense your deductible and your copay would apply. So depending on what kind of insurance you have, you would have to pay $100, $500, et cetera. This program will only reimburse whatever is remaining after your insurance pays. And that is just for the colonoscopy, any polyps or any anesthesia. These people do still meet the 250% federal poverty level, meaning that they do not have the money to pay for that copay.
Okay, Representative Ward, question.
Thank you, Mr. Chairman. So the language in the bill expands that where it was not covered before, because the law previously, before this proposed bill, did not include that the program shall pay expenses not covered by insurance for persons who are underinsured. So we're expanding that here. Is that correct?
Ms. Jones.
Mr. Chairman, Representative Ward, it's outlined in program rules that we are allowed to cover individuals who have insurance. So it may not have been previously outlined in the statute. The language that's clarified, the true purpose of clarifying that language is more in reference to the Medicaid or the Medicare part for eligibility. And so that was an attempt to clean up that language. So previously it says who have not become eligible for federal Medicare program. The updated language is actually to try to alleviate that cloudy language because the way that it's worded right now, the program would have to determine if somebody was eligible for a Medicare program. That's what the attempt at that language was to clear up. Uninsured is outlined in the program rules, underinsured, sorry.
And Mr. Chairman,
Go
if I
ahead.
might add, Representative Ward, I think the spirit here is that it's a health interest for the state that, the whole point of the program is whether you're uninsured or underinsured, having those high deductibles or out-of-pocket expenses. We do see folks that say, well, I'm not going to get that preventive screening because it is high. And so we have the program eligibility guidelines that Ms. Jones mentioned. But I would just say your point's well taken on whether or not this appears as an expansion, but based on the current program operations, it isn't that way. But from my perspective, I think it's the public health benefit that certainly outweighs that when this is a very low cost, relatively low cost service to potentially catch some very expensive and very devastating disease later on.
Further questions to the department, Representative Penn.
Thank you, Mr. Chairman. So looking at the fiscal note again, this one looks like no fiscal note, which I understand that, but could you give me an idea of what this program costs? Because what we're doing here is we're saying that anytime the guidelines change, then basically the state cost is going to change as well, right? So it used to be 50, now it's 45. And so what has that impact had on the cost that we put forth to this? And if it goes down to 40, then, every time we have an increased fiscal note and we haven't authorized it. And so I'm just wondering what is the cost of this?
Mr. Chairman,
Go ahead.
Representative Penn, I'll have Ms. Jones talk about the cost of the program. Like we discussed on the previous bill, the budget doesn't change here. So as Chairman Baldwin mentioned, that none of the cost will change when we in years when we get to the point where we're out of money, then a waiting list begins. And so if the guidelines were to change in the future and we see, a far higher volume of people trying to utilize the program, unless the legislature acted to appropriate additional funds, we would still be checked by that budget. But Star, do you know off the top of your head our program budget?
Ms. Jones.
Yes, Mr. Chairman and Representative Penn, we have $400,000 per year budgeted for colorectal cancer screenings. It's all state dollars.
Representative Penn.
Could I just follow up on that? So how long has the budget been 400,000? Did it change when the guidelines changed, or it's been the same, whether it was the age was 50 or the age is 45, it's still been 400,000?
Ms. Jones.
Mr. Chairman, Representative Penn, actually, the colorectal budget was reduced in the last biennium. So it was a little bit higher, but now it is $400,000, and that we have not exceeded the amount of colonoscopies that we can pay for this year or the previous year. So we don't anticipate that it will be an impact.
Okay, Representative O'Hearn, yep, then.
I do. Thank you, Mr. Chairman. It seems like the I have two questions. It seems like this actually limits who is eligible for this based on your insurance now, rather than the way that the law is currently written, it doesn't have any insurance eligibility requirements. It's just open to all Wyoming residents. So that's one question. Then could you just elaborate on the way that the current voucher is paid now? They administer the care, the provider takes that voucher and then submits it. And so now it's just going to be electronic. So just expand on those two things. Thanks.
Go ahead, Ms. Jones.
Mr. Chairman Zelenitzer and Representative Hornick. So the program transferred to Medicaid electronic billing in 2017. We issued ID cards to patients instead of the previous voucher. This was just in an effort to expedite the process for providers to recognize that a patient was enrolled in the program. So providers have been submitting electronic claims for these services since 2017. This language was just updated in the statute since we were already going in here to update the statute. This really won't change any way that the program is operating or performing the voucher part. It just since we were already going to be languages or updating the language, this would be just an opportunity to update that language to our current process. And then I apologize, could you repeat the first question?
Oh, I can cover it. If you look in subsection C of the statute, right now, we're starting with D. C is where it still says your income has to be below 250% of the federal poverty level to participate. So while not in this bill, A, B, and C in the statute cover the parameters of the program. Representative Clouston.
Thank you, Chair. I think it's a great program. I'm just wondering how many people are using the program per year?
Ms. Jones.
Mr. Chairman and Representative Clouston, we serve about 300 Wyoming residents per year.
While we're talking about any studies to say that if we drop it to 45, how many more there might be based on any other averages of other states or what we're expecting?
Chairman Zwonitzer, we've been tracking how many applicants we receive for patients that are under the age of 50. And so in 2022, we denied 72 applicants, 59 the previous year. So less than 100, I would anticipate that would be applying that would become eligible. And then the studies for the colorectal cancer screening do show that more and more cancers are being diagnosed at earlier ages. So we do anticipate that the USPSTF, which is the national organization who creates these guidelines, may come back in the future and change the age to earlier, which is why there's not a specified age outlined in the statute.
Okay. Seeing no further questions, thank you much. Other people here to testify on Senate File 11? Nope, not the hospital. Seeing no further public comment, let me check Zoom real fast. Seeing no comment online either. We'll close public comment on Senate File 11. Committee, what's your pleasure? Moved by O'Hearn, seconded by Chadwick. Any discussion or amendments, committee? See, Representative Ward.
Thank you, Mr. Chairman. I'll be a no for similar reasoning as for my last vote. I view this as expanding and it's just not the role of government. So thank you.
Question being called on Senate File 11. Marilyn, if you'd call the roll.
Representative Chadwick.
Aye.
Representative Clouston.
Aye.
Representative Hornock.
No.
Representative O'Hearn.
Aye.
Representative Penn.
Aye.
Representative Trujillo.
Aye.
Representative Ward.
No.
Representative Yin.
Aye.
Chairman Zwonitzer.
Aye.
The bill passes 7 ayes, 2 noes.
All right, committee, Representative Yen, O'Hearn, and Clouston have all taken a bill. Other 2 aye votes. Representative Penn, you want this one? The floor manage? All right, we'll let Representative Penn take that. With that committee, I think we only have 1 bill left right now, but we'll see what the speaker assigns to us for Monday. And I'll have that notice out by 3 o'clock.
Sooner, please.
Sooner than that, because we're leaving at noon today, I think. So with that, we're adjourned. Have a great Friday.
Thank you.